Well, it is a great honor for me to introduce the 80th President of the American Association of Neurological Surgeons, Dr. Mitchel Stuart Berger. 2 years ago, as some of you may remember, Mitch introduced me as President of the AANS in Denver. As they say, what goes around comes around, Mitch. I've known Mitch now since 1984, when Mitch was a resident in the neurosurgery program at UCSF while I was working on my PhD. Over the past 29 years, our career paths have intersected quite fortuitously on numerous occasions, and Mari and I consider Joan and Mitch to be our dear, close friends. But how did it all begin for Mitch? Mitch was born on New Year's Day, January 1st, 1953. In fact, he was the first baby born on Miami Beach that year. He grew up in Miami with his older brother Bruce and his parents Normadine and Howard Berger. At an early age, and as with other AANS presidents, Mitch developed passion for playing football in the streets and sandlots of Miami. He won the kick, catch, and run contest for his age group in Florida. He went on to play football at Coral Gables High, where his team won the national championship. Mitch became high school All-American first team, playing defensive tackle, and was the Miami Herald Prep Athlete of the Year in 1970. With his prowess on the gridiron in high school, Mitch was recruited by more than 100 colleges to play football. Some of these included the University of Alabama, Notre Dame, and Stanford. Although he signed a football scholarship at Stanford University, he chose instead to attend Harvard College in 1970. At Harvard, Mitch played defensive end and was all Ivy League and all East despite suffering a knee injury and missing one season. His coach was Joe Restic, who was interestingly from Hamilton Tiger Cats in the Canadian Football League. Well, Mitch recovered from this injury and was able to play in the highly competitive, but now defunct, North-South Collegiate All-Star Game in 1972. Quite remarkably, Mitch then signed with the Chicago Bears as a free agent in 1973 and followed his dream to be a professional football player, but the fame and glory were short-lived due to a recurring knee injury. Mitch then decided to enter medical school at the University of Miami, where Drs. Hubert Rosamoff and Barth Green had great influence in steering him towards a career path in neurosurgery. In 1982, Mitch matched to the UCSF program in neurosurgery and began his residency under Dr. Charles Wilson, who served as one of Mitch's lifelong mentors. During residency, Mitch met the lovely Joan Hurwitz, who was at the UCSF Dental School working towards a degree in dental hygiene. Mitch and Joan were married in 1983. In this wedding photo, one sees Neil Martin and the boyish-looking Nick Barbaro, Mitch's co-resident at UCSF. At UCSF, Mitch developed his academic interests in neuro-oncology thanks to Mark Rosenblum, Victor Levin, and Takao Hashino. In 1984, Mitch's and Joan's first child, a daughter, Lindsay, who's here today in the front row, was born at the UCSF hospital. In rare footage, never shown before in public, we see Mitch as he appeared as a resident in 1985 carrying Lindsay at my son Daniel's first birthday party. Let's watch. Upon completion of residency, Mitch did a fellowship in pediatric neurosurgery at the Hospital for Sick Children in Toronto under the tutelage of Drs. Humphreys, Hendrick, and Hoffman. In 1986, Mitch then began his first faculty appointment in the Department of Neurosurgery at the University of Washington in Seattle under the direction of Dr. Dick Wynn. There, Mitch did both adult and pediatric neurosurgery, specializing in brain tumor surgery. Mitch became professor of neurosurgery in 1997 and was awarded several grants from the American Cancer Society and the NIH for his work on drug resistance in brain tumors. Mitch was further mentored by George Ogeman and developed an interest in brain mapping to enhance the extent of resections of gliomas in eloquent regions. He also pioneered a method to map subcortical motor pathways that is now used worldwide. In the lab, in collaboration with his long-standing friend Francis Alley Osmond, Mitch worked out the basic mechanisms of alkylating agent-induced DNA damage in brain tumors. In 1988, Mitch and Joan were blessed with the birth of their second child, a boy, Alex, who's also here. The Berger family became very fond of Seattle as a city in which to live, and Lindsay and Alex thrived at school and in their new activities. In 1997, Mitch moved back to San Francisco and became the professor and chair of the Department of Neurosurgery and director of the Brain Tumor Research Center. Mitch successfully renewed the long-standing program project grant at UCSF in Neuro-Oncology. He also obtained the first NCI-funded SPORE grant in the country for brain tumors. This grant was just successfully renewed for its third cycle beginning 2013. Well, it's a relatively easy transition for the family to move back to the Bay Area. Lindsay and Alex thrived in their new home environment. As chair of the department, Mitch continued to push the new frontiers in the mapping and safe resection of human gliomas. Over his career, Mitch has published an incredible 450 peer-reviewed publications and over 100 book chapters. He has been awarded the Bittner and Farber Award from the AANS, the Wynne Prize from the Society of Neurological Surgeons, and he was recently inducted into the University of Miami School of Medicine Hall of Fame. He is Secretary of the American Academy of Neurological Surgery, past President of the Society for Neuro-Oncology, Vice Chair of the AANS, and former Chair of the Editorial Board of the Journal of Neurosurgery. Mitch has returned to the gridiron in his remarkable work with Rich Ellenbogen and Hunt Berger as a member of the NFL Head, Neck, and Spine Committee. Interestingly, Mitch has attended the Super Bowl for each of the last 20 years, and he considers this to be a highlight of his year. Well, what is the secret of Mitch's success? I was hoping to glean some answers from an in-depth look at his workplace at UCSF and, in particular, at his office. His colleagues were a bit tight-lipped and unwilling to impart too much information. However, I did pry loose the fact that Mitch likes to listen to music in the operating room, and he has his favorites which help him move his cases along at great speed. Ladies and gentlemen, I have it from a reliable source. Mitch, that's courtesy of Lindsay, by the way. Well, I cannot think of another president and first lady more deserving than Mitch and Joan to lead the AANS. As president this year, Mitch has moved the yardsticks for the organization farther than any president to date. He has taken the AANS to an all-time new level of achievement and influence in neurosurgery. Scholar, athlete, scientist, master neurosurgeon, educator, administrator, and leader par excellence, Mitch sets the standards for faculty by which all others are measured. But more than that, Mitch is a devoted husband and father who cares deeply about his family. When our daughter Marissa was in the Bay Area working a couple of years ago, Mitch and Joan opened the doors of their home to her. They made her feel as though she were part of their family. Mitch and Joan and I feel privileged and honored to call you our dear friends. Well, Mitch, it is now time for you to come forward to show us the meaning of your year as president of the AANS. Ladies and gentlemen, I give you the 81st President of the AANS, Dr. Mitchel Stewart Berger.
It is true, I was stuck on the Backstreet Boys, and I still love that group, sorry. Well, thanks, Jim, for those very kind words. You know, you and I have been great friends and colleagues since we were residents, and with that wonderful introduction, I'm happy to say nothing's going to change. Well, it's been a great honor for me to have served as your president over the past year, and I want to thank all of you for giving me this wonderful opportunity. There are many other people I'd like to thank who have supported me along the way. The AANS executive staff led by Tom Marshall, Katie Orico and the Washington Committee staff, our AANS executive committee, the board of directors, the annual meeting leadership team, Nick and Anil, the UCSF Department of Neurosurgery, which celebrates its 100th anniversary this year, along with its residents, faculty, nursing and operating room staff, clinic and academic staff, our medical illustration division led by Ken Probst, who built this presentation, my previous mentors, including Charlie Wilson, who's here with us today, along with several past AANS presidents, my two colleagues on the NFL Head, Neck, and Spine Committee, Hunt and Rich, and my travel club and their families, who have been a great source of inspiration and support to me over the years. And of course, my family who's here today, including Alex, Lindsay, Joan, and her dad. I'm very lucky to have two great kids who have been incredibly supportive and loving, despite me not being around very much over the years. They've done a fantastic job finding their way in the world, and now I hope to be there to support them in their lives. And as for Joni Berger, while it was my fate to train to be a neurosurgeon in San Francisco, it was my destiny to meet and fall in love with Joan while I was a resident at UCSF. If there's a reason I'm here today, it's because we share a love and respect that transcends everything else. For sure, the best part of me is all of Joan. Thanks. So, I have a confession to make. I've always been obsessed with patient safety and well-being, and while a lot of situations contributed to this over the years, there have been certain cases that serve as dramatic examples of how even the most straightforward of clinical situations can go wrong quickly due to preventable medical errors. I want to share one such case with all of you from our neurosurgical service that continues to emphasize to me how critically important patient safety is for all neurosurgeons to embrace. The following is based on a true case of a 67-year-old gentleman who came into the neurosurgery service with a fairly straightforward problem of a high-grade glioma. He had several comorbidities, but overall he was in reasonably good shape. Now, our service proceeded with a craniotomy, resected the tumor, and he was taken to the ICU and transferred to the floor on the first postoperative day. When he got out of bed, he appeared winded, and his vital signs started to change, including his oxygen saturations. The nurse on the ward called the primary neurosurgery team and waited for a callback, but the resident was busy in the OR and could not come see the patient. So the nurse called the on-call resident on the floor, and after 15 minutes, got a call back that he was in the emergency department triaging calls and also couldn't come. Well, there's a rapid response team made up of nurses who were paged, and they called back, but unfortunately they were busy stabilizing another patient. So as you can see, there was a perfect storm evolving here. Well, the nurses got together and talked amongst themselves, and while they were trying to triage the situation and the patient was deteriorating, the rapid response team came now 1.5 hours later, and the patient was spiking fevers, dropping O2 sats, was an AFib with ST depressions, and a blood gas was drawn that clearly demonstrated he was hypoxic and acidotic. Chest x-rays showed pulmonary infiltrates bilaterally, and therefore the diagnosis was septic shock. After 2.5 hours, everybody agreed to transfer the patient to the ICU to treat him for sepsis. But prior to transfer, the patient became unresponsive, and a code blue was called. And despite being coded for 45 minutes, the patient didn't make it through this event and died. So what went wrong in this case? Well, there were problems with communication. There were system-based errors. There were authority gradients that prevented people from doing their work despite the patient decompensating. Now, at the end of this talk, I'm going to come back to this case to see how differently it may have turned out based on everything I'm about to tell you. Like all of you, I was trained to be an outstanding neurosurgeon. I have always had an intense personal responsibility and pride for my patients. I considered any errors or bad outcomes to be personal failings. There was a team around me to give me support, but I didn't always welcome their input. And I'm sure on several occasions and unintentionally created an environment which others found difficult to challenge me. I resisted standardized approaches, thinking that my work was as much art as science. And altogether, I'm sure this compromised patient care on a number of occasions. So over the past year, I dedicated my AANS presidency to advancing patient safety and learned a lot about its history and science. And although many people date the start of the patient safety field at 12 years ago, following publication of the IOM report on the incidence of medical errors, the history goes back much longer than that. Leading up to the development of the first accreditation system for hospitals, there were several notable examples of individuals promoting safe practices for patient care. Then, following the American College of Surgeons' first accreditation system, which later developed into the Joint Commission, there was the famous Libby Zion event, when a young woman died due in part to resident fatigue. The Anesthesia Patient Safety Foundation was formed. The Harvard Medical Practice Study was published describing the number of preventable adverse events that occurred in this country, which was the precursor of the IOM report. Lucian Leap, one of the founders of the patient safety field, published his theories on errors in medicine being system-based problems. Betsy Lehman, who was a Boston Globe reporter, died of a medication overdose, and this unfortunate gentleman had the wrong leg amputated due to a paperwork snafu. Reflecting back 10 to 12 years ago as to what the state of affairs was in American healthcare, most of us thought that quality and safety was excellent, but the mental model for improving safety was wrong. In other words, it relied on the assumption that safety could be achieved by just getting people to work harder. But we now know that safety problems are due to system errors and not individual failings. There was also no business case to improve safety and quality. I mean, if a hospital CEO had extra money left over at the end of the year, they were going to invest it in a new scanner and not in teamwork training. There was no local expertise or research on the science of safety, so therefore best practices had not been established. So all of this led to very predictable results, that safety and quality was not very good. Well, the Institute of Medicine published its report in 1999 entitled "To Err is Human, Building a Safer Health System," and was based on that Harvard Medical Practice Study, estimating that up to 100,000 people die each year from medical errors. And while that was shocking in itself, the IOM put a spin on it, and they equated this to a large jumbo jet crashing every day for 365 days. Now, obviously, if this happened, there would be no limit to what we would do to fix the problem. Following the IOM report on safety, they put out another such report on quality. The National Quality Foundation reported its list of never events, and CMS linked this to payment penalties for hospitals. The RAND Corporation published a study showing that when physicians know how best to practice, they only do it 50% of the time. The ACGME mandated its first work hours restriction at 80 hours. Hospital Compare was launched by Medicare as a public reporting system, therefore increasing transparency to promote safety and quality. The Joint Commission established key practices that all hospitals have to follow and changed their notice as to when their surveys would be done, such as on the day of their visit. The Patient Safety and Quality Improvement Act of 2005 was signed into law, making it safe for providers and organizations to voluntarily disclose information on medical errors without the fear of legal repercussions. Don Berwick, who you heard from earlier, launched the Institute for Healthcare Improvement and a campaign to save 100,000 lives in hospitals. Peter Provenost, who's an intensivist at Hopkins, developed a checklist to reduce central line infections and put this into effect in Michigan ICUs, reducing the infection rate by 50%. Dr. Berwick became head of CMS for 1 year. The federal government put a significant amount of money via the stimulus package into health information technology. The ACGME changed the work hours once again, preventing interns from working more than a 16-hour shift, and CMS launched its value-based purchasing strategy, withholding money to hospitals for not practicing safe, high-quality care. So in essence, there was a lot of activity over a short period of time. There became a growing business case for safety and quality, and the transition was made from the weak forces with little or no consequences to much stronger pressures, such as the unannounced Joint Commission visits, CMS payment penalties, etc., that essentially mandated tangible efforts to demonstrate safe practices and quality improvement. And while the Healthcare Reform Act promoted this change, this was going to happen regardless, because all of us recognize the need to remake the healthcare delivery system in order to survive in the brave new world of healthcare reform. So we knew we needed to fix things, but what have we learned to focus our efforts? Well, at first, we needed to develop a systems-based approach to categorize and analyze errors, along with creating the tools to provide solutions. Secondly, we had to realize how important culture underlies practices and attitudes. You know, this has often been defined as the way we do things around here. And finally, all of this was going on within the context that healthcare is a complex adaptive system, meaning it's a very fluid, unpredictable environment in which a very prescriptive top-down approach is going to be ineffective and counterproductive. Now, another way to look at this is what can be referred to as the patient safety ecosystem, where various external forces such as regulations and accreditation, transparency, malpractice risk, payment policies, social pressures, and even media work to create a different level of accountability, influencing what is inside the ecosystem, namely systems-based approaches, creating a safety culture, and establishing a very safe, well-rested workforce that embraces the concepts of professionalism. So why did we need a systems-based approach to patient safety? Well, we've made a lot of progress over the past 50 years when medical care was much simpler and slower paced, but now things are quite different.
I really could walk, you know.
Hospital rules, more rigid than steel, more inflexible than granite.
Well, this is a modern ICU in my hospital, and just think about this for a second in terms of how complex an environment it is. If your thought process for improving patient safety was based on having infallible people working really hard to do the best they could and not make a mistake, the reality is this couldn't possibly happen. Instead, the only way to deliver safe care for our patients is to embed fallible yet conscientious people in systems of care that identify or anticipate errors and block them before they occur. This is the task we have in front of us today and well into the future. So we're at a point in our healthcare environment today that we do have systems in place that enable us to analyze our errors and implement processes to prevent them from occurring, similar to other industries such as aviation. And we've advanced our understanding and utilization of health information technology such as computerized physician order entry and barcoding to reduce the incidence of many preventable errors. Well, I want to turn now from the complexity of healthcare to the culture of healthcare. And to emphasize this point, I want to go back to 1977 and the worst airline accident in aviation history. And it'll serve as an example of how the airline industry changed the culture in the cockpit, preventing this type of event from ever happening again. So on the runway in Tenerife, there was a KLM jet lined up to take off, and the fog was rolling in, and at the opposite end of the runway, there was a Pan Am jet taxiing off the runway to follow the KLM jet. There seemed to be some confusion in the cockpit with the pilot, flight engineer, and co-pilot in regard to tower communications. It was not certain whether or not the Pan Am plane was clear of the KLM 747, and perhaps influenced by his great prestige, making it difficult to imagine an error of this magnitude on the part of such an expert pilot, both the co-pilot and flight engineer said nothing further, and the pilot took command and started down the runway. The plane took off, hitting the top of the Pan Am jet, and resulted in 600 deaths and the worst aviation disaster in history. But this resulted in the airline industry developing what is known today as crew resource management for teamwork training in the cockpit. So how well do we do with this concept in healthcare? Sexton did a study where he asked operating room crews how good teamwork was in their ORs. Well, nearly 80% of the attending surgeons said teamwork was excellent, but all other individuals across the spectrum didn't agree. And this points out the problem of steep authority gradients in which individuals at the lower end of the spectrum are not willing to come forward and voice their concerns when something is not quite right. Now, Sexton also asked pilots and surgeons whether they would want someone to question them if it was felt that something was not right. And whereas almost all pilots said they'd be okay with that, only 50% of the surgeons said it would be okay to question them. And you can see where this comes from. Namely, the surgeon feels that they're in control, and they're often above reproach, which is exactly why there are authority gradients in most operating rooms today. And the other complicating aspect of safety culture is that it's a local phenomenon. There was a study by Sexton and Provenose where they looked at the safety climate across 100 hospitals and demonstrated that there is a great deal of variability in the feeling individuals had about being in a good safety climate. Then they looked at one hospital at the 50th percentile and showed that there was an even greater degree of variability within the 49 units in that hospital, such as radiology, ED, OR. Well, as complex as culture and systems-based approaches are, healthcare in our country seems to be always changing, creating a great deal of uncertainty. Problems can't be solved in a rigid machine-like fashion, although sometimes they can be moved forward in that way. Individuals are really independent, yet interdependent, creative decision makers and need to be listened to at all levels. Solutions often emerge from situations with minimal specifications and simple rules. The bottom line is that a really good, safe organization has to take all of this into account to implement systems and change culture to address the needs of this complex adaptive environment that we all work in on a daily basis. Well, here's a question for all of you. What do you think the most important innovation is in the patient safety field since the IOM report? Well, there are a lot of good choices here, but I would contend that it's actually something else. In fact, it's the checklist, which is the most important innovation in the last decade in the patient safety field. Here is evidence of the impact the checklist has made by decreasing central line-associated bloodstream infections. And following the drop in infection rates in Michigan ICUs, the Agency for Healthcare Research and Quality rolled out the checklist throughout this country and reduced central line infections by 30 to 40%. This is the WHO surgical safety checklist developed by Gwandi that most of us use today. But Gwandi did a study where he asked surgeons how often they use the checklist in the OR, and about 30 to 40% of the surgeons said they never used it, didn't think it was valuable. But when he asked the same surgeons, if you were having surgery, would you want your surgeon to use the checklist? 90% of those same surgeons said yes. And these are outcomes before and after using the checklist, showing dramatic, significant differences in surgical site infections, unplanned returns to the operating room, deaths, and any complications. And while this is only one evidence-based approach to patient safety, it's critical to keep in mind, as important as this has been, that there is no one solution that always works, and good safety programs really have many approaches that are effective. Well, let's now turn to how we are doing in neurosurgery. with regard to promoting patient safety and quality improvement, we seem to be quite far behind our medicine and general surgery colleagues in the number of publications in these areas following the IOM report. There are a number of themes in the literature that I want to briefly highlight. With regard to neurosurgical adverse events, there was an excellent recent review of the literature from Gwande's group, which looked across different neurosurgical procedures and categorized the factors that contributed to adverse events. And this included everything from surgical technique to communication. Our group, led by one of our residents, did a further meta-analysis of the literature and identified two studies in particular which provided relative frequencies of these contributing factors leading to neurosurgical errors, although I personally think poor communication is underestimated. Certainly, one strategy to reduce errors has to do with volume-outcome relationship in neurosurgery. There is increasing evidence across many different aspects of neurosurgery that high-volume surgeons and hospitals have better outcomes with certain procedures, thus bringing up the issue of regionalization of care for certain types of operative procedures. So in essence, the neurosurgical literature overall suggests that error reporting is low and that most of the errors we see are related to surgical technique, poor judgment, non-adherence to protocols, and communication problems. Errors need to be disclosed in a non-punitive setting. We're going to have to consider regionalization of care to higher volume providers and hospitals for certain types of neurosurgical disorders, and we need better information in order to promote changes such as with national benchmarking data. Now, you'll learn more about our National Neurosurgery Quality and Outcomes Database, N2QOD, at this meeting, and I want to thank Matt McGirt and Tony Asher for providing this striking data. As you can see, this effort has grown to involve over 40 hospitals and 4,000 neurosurgical patients since it was implemented over a year ago. And what you see here from the lumbar spine module shows real-time neurosurgical data on our outcomes, including 30-day morbidity and readmission rates, as well as the likelihood of reoperation in 90 days. In addition, N2QOD offers the ability to compare your own performance with expected outcomes, thus providing the information needed to change the way you may be doing things to decrease adverse events. Now, I previously referred to the utility of the checklist, and in neurosurgery, there have been a number of publications written about its use. I want to highlight one of those studies by our neurosurgical colleagues at the Mayo Clinic in Arizona, in which they hit on the critical factors to why checklists work to prevent errors, namely compliance. And as you can see, with their compliance being nearly 100% in over 6,300 operations, there have been no wrong site, wrong procedure, or wrong patient never events during the course of its use. Yet we know this happens. But how often? This is UHC data which reflects on both academic and affiliated medical centers using ICD-9 diagnostic codes for these never events, and only 9 such events were recorded over a 3-year period. Data from the AANS Credentials Committee identified 41 wrong site surgeries in a 10-year period. Data from the Joint Commission reported nearly 900 wrong patient, wrong site, wrong procedure events throughout surgery in general over an 8-year period. And if we break out just neurosurgery, there were 27 never events in this 8-year period. So this averages out to be, well, probably about 2 to 4 events per year. But then you have an article like this that came out of a Canadian survey where 25% of polled neurosurgeons reported making an incision on the wrong side of the head, and 35% reported wrong level lumbar surgery at some point in their career. Mark Bernstein and his colleagues in Toronto looked into this further and estimated that there were about 2.2 per 10,000 craniotomies per year done on the wrong side. Well, considering there are nearly 550,000 craniotomies done per year in the U.S., this equates to approximately 120 wrong-sided craniotomies per year. And with regard to lumbar operations, a recent study by Smith and colleagues supports the Canadian incidence of 33% of neurosurgeons surveyed who said they had done one wrong level sometime in their career. And based on data that I got from Chris Shaffrey using Medicare lumbar spine surgery rates, this translates out to about 90 cases per year for this patient population. And if you do the math regarding the likelihood of operating at the wrong level, the numbers are much higher. And this is from a recent article in the AMA News showing that these so-called never events, which also includes retained foreign bodies, occur 80 times per week in ORs all around the country at all surgical specialties. Now, whether you believe this or not, I think it's important to point out that these never events do cause fatalities and permanent injuries. So to prevent these events from occurring, we must achieve complete compliance across the country in neurosurgery, just like how it was done at UCLA, following implementation of their patient safety program. So the data on never events is fairly limited and reflects a lot of inconsistencies. We have to change our culture to be more transparent and increase reporting, and this is where N2QOD is going to be very important. The neurosurgical literature on checklists is sparse. Only half of the published literature addressed outcomes, and of those that did, findings clearly show that the checklist reduced errors. So we must mandate standard perioperative safety checks, realizing how important they are in the high-risk world of neurosurgery. With regard to creating a culture of safety, with everything that's been written, it really all boils down to three main themes, namely teamwork training, similar to what was done in the aviation industry, better communication among surgical teams, and not just during timeouts and debriefings. And we have to get rid of steep authority gradients that prevent people from speaking up when something is just not quite right. With regard to the ACGME resident duty hour restrictions, a number of themes have emerged from the literature, but the take-home message here is that these restrictions seem to be adversely affecting resident training. And while mortality rates remain unchanged, the morbidity rate on neurosurgical services with residents has increased. And this is most likely due to the fact that there are more handoffs in patient care, thereby increasing the opportunity for errors leading to complications. Now, it's interesting to note in this recent New England Journal publication, which surveyed residency program directors, that 36% of them believe patient safety has been made worse with the new regulations. Currently, 27% of residents feel that patient safety has deteriorated since the 2011 ACGME regulations went into effect. And a recent study demonstrated that the percentage of interns who reported concern about making a serious medical error increased from 19.9% to 23.3% following the 2011 duty hours reform, which is a 17% increase. Well, the IOM is addressing this now and has appointed a committee led by Dr. Berger to recommend changes to the current GME system. These deliberations have begun, and neurosurgery is well represented by our very own Ralph Daisy, who has testified in front of this committee. With regard to neurosurgical simulation, there's really no question that the current generation of simulators is getting much closer to what has been achieved in the airline industry. Currently, few accredited training programs are using this technology, whereas many have indicated these simulators will be very useful for education and surgical skills training. Following the airline industry, there's increasing use of simulators within healthcare, realizing the potential they have to decrease surgical risks and improve patient safety and OR efficiency. This could fundamentally change the way we not only train our residents, but how we maintain our own skills later in life. Perhaps having to pass a simulator training test as part of the maintenance of certification exam. Now, at the beginning of my presidency, I sent around a survey to all the AANS members asking you to tell me about your own patient safety efforts. I thank those of you who took the time to respond from various types of neurosurgical practices, patient volumes, and hospital environments. The top 3 QI and safety priorities were in alignment with national trends in all surgical disciplines. The incidence of medical errors was similar to the available literature, namely all over the map or unknown. About half of you indicated that there were employees within your group dedicated to QI and safety issues, and that these individuals were on loan to the group from the hospital or from another department. And as you can see, this is not an inexpensive commitment to quality and safety. While most reported following a preoperative checklist, the communication exchanges in the operating room and postoperative setting were less than ideal. The vast majority of you who responded and are affiliated with residency training programs stated there were no QI and safety education courses in place, although there was a strong interest in doing this, and that simulators are seldom used. So, to say the least, we have our work cut out for us. So how do you build a patient safety program? Well, it starts with a vision that you and your colleagues must have to provide the safest and highest quality patient care possible. There are a lot of components to this process, and I want to briefly go through this. The first piece is that you must have dedicated personnel. In our unit, we hired 2 hospitalists who work in the QI and patient safety field. And I'm pleased to say that Kat Lau is here today in the audience, and I owe her a great deal for the success of our program. Secondly, you have to start somewhere. So we developed a neurosurgical perioperative safety video and required everyone going in and out of the OR to view it and complete an online self-assessment survey in order to be present in the OR. Well, the number of correct answers in perioperative safety knowledge increased by 80% after implementing this video. And although our complication, or our compliance ratio, I should say, were pretty good to start with, we are now at 100%. As importantly, our debriefing compliance rates are much greater now than they have been in the past, and will continue to strive for excellence in this part of teamwork training. We implemented a quality improvement dashboard to understand how we are performing in terms of clinical effectiveness, efficiency, and the patient experience. We wanted to standardize the data sources we pulled the dashboard from, along with the reporting frequency. The purpose of the dashboard is to increase transparency, target interventions when needed, along with promoting accountability and building a safety culture. We developed a QI project portfolio, and I want to highlight a few of these areas. One good example in terms of reducing hospital-acquired conditions very specific to neurosurgery had to do with our mannitol infusion pilot. Now, we were having a problem with mannitol extravasation. We had 40 such incidents over a 3-year period that resulted in over $1 million in legal claims. So we put together a multidisciplinary committee and decided to use larger bore IVs or PICC lines, standard infusion pumps, and a nurse continuously observing the patient until the infusion was complete. And since that time, we've had no examples of mannitol extravasation, and this is now hospital policy. We're also working hard to decrease readmission rates, and we implemented a program with post-discharge phone calls within 72 hours to the patient after discharge to proactively address any patient concerns or questions. We rolled this out on the neurospine service, and early indications appear to show favorable results in reducing readmission rates. This will now be expanded to all discharged patients on the neurosurgery service. We also established a morbidity and mortality case review committee in addition to our usual monthly M&M conferences. The purpose of the committee is to drill down into these reported errors one by one using a root cause analysis format to determine how to prevent these errors from ever occurring again. We've also implemented a resident quality improvement curriculum. And in fact, it's an ACGME requirement to teach our residents systems-based practice and practice-based learning. It's now a requirement in our department to complete this in order to graduate from our residency training program. This innovative curriculum combines online module learning in addition to classroom sessions. This gives you an idea of how this program is spread out longitudinally over a 6 and soon-to-be 7-year residency training program. And this all culminates in a QI project, such as the one seen here, which reduced lab utilization on our service by 32%. And this year, we're going to increase our postoperative communications through completion of postoperative notes in a timely fashion. We've implemented a co-managing hospitalist service over the past 3 years to cover medically complex neurosurgical patients with certain medical comorbidities. Now, the innovative aspect of this program is that all neurosurgery providers, but not just MDs, are able to directly communicate with the co-managing hospitalist, thereby preventing delays in management and decreasing the risk of steep authority gradients. So with everything I've told you regarding the history of the patient safety movement, the current literature that exists in neurosurgery, as well as the components of a successful safety program, I want to show you how putting all of this together could have changed the outcome in the case that I presented previously. So when the patient gets symptomatic and the vital signs change, the ward nurse immediately calls the co-managing hospitalist, and together they begin the evaluation of the patient with or without the resident or attending neurosurgeon. The rapid response team is staffed upward so they can now free up at least 2 people to come and help at the bedside with the triage process. Altogether, a rapid consensus opinion is built, a diagnosis of impending septic shock is made, and the patient is immediately transferred to the ICU, followed by a progressive improvement, ultimately leading to discharge. So in essence, we can take a situation where we know what went wrong due to miscommunication, faulty systems, and steep authority gradients, and using all these strategies to understand and improve patient safety, we can hopefully avoid in the future what happened to this patient in the past. Finally, and in closing, I want to comment on what I think it's going to take to be a great neurosurgeon in the future. An appropriate analogy might very well be how the modern astronaut evolved. In reading Tom Wolfe's novel, The Right Stuff, the early days of space flights involved brash young test pilots like Chuck Yeager, who epitomized the fly-by-the-seat-of-the-pants, rabble-rousing individualists with that Top Gun mentality. However, this gave way to a new generation of astronauts, John Glenn, Sally Ride, who, somewhat differently than Yeager, were highly professional, highly trained individuals, engineers, physicists, who believed in teamwork training and systems-based approaches, realizing they were fallible human beings working within systems that anticipated errors and blocked them before they occurred. The neurosurgeon of the future has to embrace the ideals of individualism and innovation while never giving up the art of medicine, prioritizing the doctor-patient relationship, and changing our culture to practice the science of medicine within systems that help us to understand and prevent errors from occurring. And if we can achieve this, we will create an environment that ultimately benefits our patients and protects them to the greatest degree possible. Simply put, we have to make this a priority now and forever. Ladies and gentlemen, thank you very much. Thank you.